In this video, we are going to be looking at the condition Alport Syndrome. Hi, I'm Sharon. I'm working as an assistant professor at M College of Nursing. The following are the objectives that we'll be addressing in this video. Now let's look at the introduction and the definition of the topic. The term Alport Syndrome, short form referred to as AS, it is a group of heterogeneous inherited disorders involving the basement membrane of the kidney and commonly affecting the cochlea and the eye. It was observed that hematuria was the most common symptom and males were affected more than females. Other terms include hereditary nephritis and hemorrhagic familial nephritis. This occurs due to a gene abnormality that codes for type 4 collagen and presents in patients with hematuria, edema, and hypertension. In 80% of the cases, AS is inherited in an X-linked pattern and caused by COL4A5 gene mutations, although other inheritance patterns also exist. It can be inherited as an autosomal recessive or dominant pattern by mutations in COL4A3 or COL4A4 gene. Now let's look at the history. In 1927, the syndrome of hereditary nephritis and deafness was described by a British physician, A. Cecil Alport. In 1961, it was named Alport Syndrome after having been observed in multiple family members. It is characterized by renal failure, bilateral sensory neural hearing loss, and eye abnormalities. Eventually, the patients present with proteinuria, hypertension, progressive loss of kidney function, that is, with a gradual decline in GFR, and end-stage renal disease. Now let's look at the etiology of Alport syndrome. This is caused by the mutations in the genes responsible for alpha 3, alpha 4, and alpha 5 chains of type 4 collagen. The following three genetic forms of AS are mentioned with their approximate causes. X-linked Alport syndrome. This is caused by mutations in the COL4A5 gene in 85% of the cases of AS. And autosomal recessive Alport syndrome. This occurs due to the mutations in COL4A3 or COL4A4 gene, leading to approximately 10 to 15% of the cases. And the final one, autosomal dominant Alport syndrome. This is caused by mutations in the COL4A3 or COL4A4 gene, although rare. Over 300 mutations have been observed in the COL4A5 genes in families with XLAS, and majorly COL4A5 mutations are minor, including splice site mutations, missense mutations, and deletions of fewer than 10 base pairs. Around 20% of the mutations are large and medium-sized deletions in the COL4A5 gene. A certain kind of deletion involving the COL4A5 and COL4A6 genes leads to a combination of XLAs and leiomyomatosis of the esophagus, female genital tract, and the tracheobronchial tree. Leiomyomatosis refers to benign tumors that are called leiomyomas to form in smooth muscle tissue. Moving on to the epidemiology, AS affects about 1 in 50,000 newborns, and males are more likely to be symptomatic than females. It is estimated that approximately 30,000 to 60,000 people in the United States have this disorder. In the US, the overall incidence of ESRD in children is about 3% and 0.2% in the adult population, whereas in Europe, AS accounts for 0.6% of patients with ESRD. The common X-linked type of AS resulting in ESRD predominantly affects males. However, the X-linked form of AS affects almost as many females. Affected women are generally undiagnosed, but 15 to 30% end up having renal failure by 60 years and hearing loss by middle age. AS is a significant cause of chronic kidney disease, leading to end-stage renal disease in adolescents as well as young adults, accounting for 1.5% to 3% of children on renal replacement therapies in Europe and the US.
Now let's look at the histopathology of Alport syndrome. Initially, kidney biopsy specimens examined through light microscopy may be normal. As the disease progresses, non-specific findings may appear. Focal and segmental glomulosclerosis, tubular atrophy, interstitial fibrosis, and the presence of lymphocytes and plasma cells. Immunofluorescence studies yield negative results. Electron microscopy of the kidneys reveal longitudinal splitting and multilamelation of the GBM, that is the glomerular basement membrane, lamina densa. Monoclonal antibodies against alpha 3, alpha 4, and alpha 5 chains of type 4 collagen may be used to assess the glomerular basement membrane for the presence or absence of these collagen chains. Their absence is strongly suggestive of Alport syndrome and is not seen in any other condition. As the alpha 5 chain of type 4 collagen is also expressed in the epidermis, a skin biopsy can be used to establish a diagnosis. Immunofluorescence studies on skin biopsy specimens are often diagnostic. Patients with XLAS may also display abnormalities of alpha 2 collagen expression in the skin. Looking at the clinical manifestations, in the eye we see anterior lenticonus. Here, the anterior surface of the lens can assume an abnormal conical shape. More than 90% of cases of bilateral anterior lenticonus are associated with Alport syndrome. In subcapsular cataract, the vision is impaired by opacity, particularly in the back part of the lens capsule. The next is dot and fleck retinopathy. Here, abnormal yellowish or whitish flecks or dots of pigment can be seen in the retina. There are also posterior polymorphous dystrophy and corneal erosions. In the ear, sensory neural deafness can occur. In the esophagus, there is diffuse esophageal leiomyomatosis, which is circumferential proliferation of smooth muscle cells causing marked thickening of the esophagus and subsequent dysmotility. In the aorta, one can notice thoracic and abdominal aortic aneurysm, that is, abnormal dilatation. In the kidney, there can be microhematuria, which can lead to proteinuria, fibrosis, and leading to end-stage renal disease. Bilateral cysts in the kidney can also occur. In the cardiovascular system, one can also see hypertension. To make an appropriate diagnosis, we have to collect the history. Urine analysis can show hematuria, proteinuria, acanthocytes, red blood cell casts. Renal biopsy, ENT testing, ophthalmic testing, genetic testing inclusive of molecular genetic testing, and next generation sequencing can also be done as discussed earlier. The following are the differential diagnosis that needs to be taken into consideration before confirming the diagnosis of Alport syndrome, that is immunoglobulin A nephropathy, thin glomerular basement membrane disease, acute post-streptococcal glomerular nephritis, medullary cystic disease, multicystic renal dysplasia, and polycystic kidney disease. Looking at the treatment, there is no specific treatment for Alport syndrome, but we can limit the progression of proteinuria and kidney disease by giving AC inhibitors, that is angiotensin converting enzyme inhibitors, angiotensin receptor blockers, diuretics. Later dialysis or a kidney transplant can be done. For ocular involvement, clear lens phacoemulsification with intraocular lens implantation. And for ear involvement, hearing aids can be used. Looking at the prognosis, in the X-linked disease form, about 50% of males require dialysis or kidney transplantation by 30 years, and approximately 90% develop ESRD before 40. Female patients with XLAS have a better prognosis with about 12% developing ESRD by age 40. However, studies indicate significant renal morbidity in females with proteinuria and hearing impairment. By age 60, this rate increases to about 30%, and by the same age, the rate of ESRD approaches 40%. In comparison, autosomal recessive Alport syndrome can cause kidney failure by age 20. In contrast to autosomal dominant Alport syndrome, where there typically is a delay in ASRD until middle age. The following are the references for the same. Thank you.